Picture the doctor you saw last week. For the 15 minutes she spent with you, a small army of people you never met went to work. Someone to translate your visit into billing codes, someone to submit the claim, someone to fight the insurer when it gets denied, someone to prove the hospital followed the rules, someone to keep its computers from being hacked. In a modern American hospital, a large share of the staff never touches a patient. In fact, in one study at a single large medical center, nearly a quarter of the doctor's fee for an emergency room visit went not to care, but just to the cost of billing for it. So what do all these administrators actually do, and why are there so many of them? Let's follow the paperwork. Here's the thing most people miss about a hospital. It isn't only a place that treats patients. It's also at the same time an insurance claims processor, a regulated employer of licensed professionals, a data security operation, a pharmacy, and a supply chain hub. Each of those is a real job that needs real people, and almost none of them wear scrubs. The question this episode answers isn't whether hospitals need administrators. They plainly do. It's why they need quite so many, whether that number has grown beyond what the work requires, and how you'd even tell the difference. And the honest answer has two halves that are both true at once. Let's answer it like an operator. What is all this administration actually for, and why does the United States seem to need so much more of it than anyone else? The story runs through a genuinely necessary set of jobs, a payment system that manufactures paperwork by design, a number that ranges wildly depending on who's counting, and a bloat critique that's partly right and partly a trick of definitions. Two things are true at once. Most administrative work is doing something real, and a large, expensive slice of it is waste. Let's hold both. Start with the number everyone fights about, because there isn't one. How much of US health spending is administration depends entirely on what you count. Count only the overhead of insurers and the government, and it's about 8%. Widen it to include all the billing and paperwork costs on the provider side, and the combined total reaches around 15. Count all administrative activity, as the consulting firm McKinsey does, and it's roughly a quarter of health spending. And by the broadest measure, used by researchers who happen to be single-payer advocates, so weigh it accordingly, it reaches about 34%. Notice what just happened. The same country, four honest ways of counting, an 8 to 34% spread. The range isn't a failure to measure, the range is the finding, and every number you'll ever hear thrown around lives somewhere inside it. So what is that workforce actually doing? Start with the revenue cycle. Translating every clinical act into one of tens of thousands of billing codes, submitting the claim, and fighting the denial when it bounces. Then prior authorization, getting dozens of different insurers to pre-approve care. Then compliance, proving to Medicare, to the accreditors, and to privacy law that the hospital followed every rule, with the documentation to survive an audit. Then quality and safety reporting, because Medicare now pays partly on measured quality. Then credentialing every clinician's license, running the electronic health record and fending off ransomware, managing the supply chain and choreographing beds and operating rooms. Delete all of that, and the hospital can't get paid, can't stay licensed, and can't prove it's safe. This isn't fat, it's the machine that keeps the doors open. Put a number on just one of those jobs. Researchers at a large academic health system timed exactly what it cost to bill for care, start to finish. Measured against the physician's fee for the visit, billing ate about 13% for a primary care appointment, and about 25%, a full quarter, for an emergency room visit. Now that's one health system, and it measures the doctor's professional fee, not the whole hospital bill, so it may not describe every setting. But it makes the abstract concrete. In the American system, collecting the payment can cost nearly as much as delivering some of the care. That's not because anyone's lazy, it's because of who the hospital has to bill. Or take prior authorization, the pre-approvals insurers require before they'll pay for a test, a drug, a procedure, by a survey from the Maine Physicians Association. And it's worth noting that group campaigns against prior auth, so the figure may run high. A typical physician's practice handles around 40 of these requests a week and spends roughly 13 hours, nearly 2 full working days, clearing them. That's 13 hours of a clinical team's time every week, not spent on patients, and every one of those hours needs someone to work it. Multiply that across a whole hospital, and you can watch the administrative headcount grow right in front of you, not from empire building, but from the sheer friction of the system. So why does America need so much more of this than other countries? Because the system is built to generate it. A single US hospital bills hundreds of distinct payers, commercial plans, dozens of Medicare Advantage variants, Medicaid managed care plans, traditional Medicare, each with its own forms, rules, and pre-approval criteria. A hospital in Canada bills essentially one provincial payer under a single budget. That one difference, one payer versus hundreds, is the leading explanation for the gap. Layer on decades of accumulated regulation that rarely gets removed, quality programs that each need their own reporting, and a fee-for-service model that pays you only for what you document. The paperwork isn't a bug in American healthcare. It's a direct product of how we chose to pay for it. You can see that choice in the numbers. In a study across 8 wealthy countries, administration ate about 25% of US hospital spending, and note the denominator there is hospital budgets specifically, a different study and measure than that quarter of all health spending figure from a moment ago. On this hospital measure, the US was the highest of the group, more than double Canada's roughly 12%. Two fair caveats. It comes from researchers who favor a single-payer system, and it uses data from over a decade ago. But the direction is corroborated widely, and the mechanism is clear. Single-payer countries simply have less billing to do. And in fairness, their lower administrative cost isn't pure magic. It partly reflects trade-offs Americans might not accept, like tighter budgets and longer waits. The lesson isn't copy Canada. It's that structure, not laziness, drives the number. Now the other half, because there is real excess, and pretending otherwise would be its own kind of spin. For decades, the number of administrators grew far faster than the number of doctors. You've probably seen the viral chart showing administrators up 3,000% since the 1970s, while physicians barely moved. Here's the honest read: the underlying data is real, but that eye-popping number is shaky because administrator has no fixed definition. Some of that growth is genuinely new work, privacy officers, quality abstractors, cybersecurity teams that simply didn't exist before, and some is just relabeling old jobs. The chart lumps necessary new functions and pure bloat into one line and calls it all waste. Meanwhile, at the top, by one reform advocacy group's count, non-profit hospital chief executives earn on average about 8 times a typical worker, and the best paid, many times more. Weigh that source the way we weighed the others. The direction, though, is not seriously disputed. And this isn't only a story about the past. The Bureau of Labor Statistics, a neutral government source, projects that medical and health services managers will be one of the fastest-growing occupations in the entire country, expanding about 23% over the decade to 2034, against roughly 3% for all jobs. 8 times the average. Whatever is driving the administrative build-out, it is not slowing down. The system keeps generating the work, and the workforce keeps growing to meet it. So how much of it really is waste? Here's the cleanest answer, and it comes not from the advocates, but from the consultants. McKinsey, working with the economist David Cutler, estimated that about $265 billion of US administrative spending, roughly 28% of it, could be removed within a few years without touching a single patient's care. One important caveat: that's a system-wide figure. It counts waste on both sides of the fight, the hospitals and the insurance companies, not the hospital alone. But even split across the two, it's a management consulting estimate of pure extractable friction. Duplicative billing, the prior auth arms race, manual processes a computer could do. The bloat is real and it's enormous on both sides of the ledger. But hold that removable slice next to the whole. $265 billion is a staggering amount of waste, and it's still a minority of total administrative spending. The majority is doing something real because the system forces it to exist, which points to the honest conclusion: the problem usually isn't the administrators themselves. Most of them are clearing paperwork that someone, an insurer, a regulator, a payment rule, required into being. You can't fire your way out of that, you'd just fail the audit or lose the claim. But that cuts both ways. Where the excess is a genuine choice, extra management layers, executive pay, the organization does own it. The durable fix is two-sided. Simplify the system that manufactures the paperwork and hold organizations accountable for the waste they chose. So here's the whole thing on one card. 1. Most administrative work is genuinely required. You can't run a modern hospital without it. 2. America's multi-payer, heavily regulated system manufactures far more of that work than other countries create. 3. On top of the necessary layer sits a real, removable slice of waste, hundreds of billions of dollars across hospitals and insurers alike. And 4. Shrinking it takes two moves at once. Simplify the machine that generates the paperwork and hold organizations accountable for the excess. That's a choice rather than a requirement. Necessary function and real excess. Both are true, and any honest answer has to hold them together. If you take one thing from this, hold the two halves together, because the debate goes wrong the moment you drop either one. Half the truth: most administrators are doing work a fantastically complex payment system genuinely demands. You can't run a modern hospital without them, and firing them just fails the audit or loses the claim. The other half, with equal weight: there's a large, expensive layer of real excess sitting on top. Hundreds of billions in removable friction, management layers that keep stacking, and executive pay that keeps climbing. Some of that is forced by the system. Some of it is a choice hospitals and insurers made. So the honest answer isn't blame the bureaucrats, and it isn't they're all essential. It's both at once, and the fix has to work on both. Simplify the paperwork the system manufactures and hold the organizations accountable for the excess they chose. So the next time you get a bill with a dozen line items, or your doctor's office says your medication needs prior authorization, you'll know there's an entire hidden workforce behind that friction. Mostly necessary, partly wasteful, and growing either way. But all that paperwork lands somewhere, and more it lands on the clinicians themselves. Next time, we follow it to its human cost. Why so many doctors and nurses are burning out, and what the documentation treadmill has to do with it. For more on how the system really works, visit shanewelter.com. I'll see you in the next one.